So one of the things that was in the comments that somebody asked us to comment about is the retinal hemorrhages and how can we use these retinal hemorrhages to help us determine etiology. And so the first thing you need to know is something very simple, which is red blood cells are supposed to stay inside the pipes. So if we see red blood cells outside of the piping, either the artery, the vein, or the capillary bed, then you already know it's pathologic. So there are no physiologic reasons for you to have hemorrhage. So as soon as you see the hemorrhage, already pathology. The second is, what are the things that are driving the hemorrhage out of the blood vessel? And what level of the retina is the hemorrhage? So we can be a problem with the arterial side, we can be a problem with the capillary bed, or we can be a problem in the venous outflow. The gradient that is driving the blood through this system is a hydrostatic gradient derived from the mean arterial pressure. So the mean arterial pressure, the blood pressure, is pushing the blood in through the capillary bed. The resistance and the pressure head is going to drop because you are dividing the arterial load amongst many smaller caliber vessels. And then the venous system will carry the blood back to the heart. The artery system has to be thick-walled and has to be able to get smaller and bigger to autoregulate. The capillary bed, under the law of Laplace, T equals P times R, is able to hold this pressure head. Even though that was mean arterial pressure, that was systolic blood pressure level, because the load is distributed over many small radius vessels. And then the venous side doesn't have to have that thicker wall at all because it's such a low pressure system. So we're going from a high pressure side to a low pressure side. And what keeps the blood inside the blood vessel on the arterial side is the barrier and the endothelial barrier. And those tight junctions keep the red cells inside the vessel. And so you can see now how we can end up with blood outside of the blood vessel. One of the most common is if the pressure head goes up too high. So again, law of Laplace, if the pressure exceeds the wall tension, the wall will bust and blood vessels will leak the blood. And so one of the things that causes hemorrhage is hypertension. So if you have arterial hypertension, you get hemorrhages. And because the blood vessels are in the superficial layer, they're right under the nerve fiber layer, that's where the hemorrhages occur. So if the artery is here, it's right under the nerve fiber layer. So when it leaks, we get flame-shaped hemorrhages. Those hemorrhages are flame-shaped because the nerve fiber layer is shaped that way. So the nerve fiber layer tracks to the nerve, and so hemorrhages in that nerve fiber layer look like flat little flames to you on face when we look in the fundus. So when we look in the fundus examination and we see flame hemorrhage, that hemorrhage came from that superficial vessel under the nerve fiber layer, and that's a super common hypertensive type headache. However, if we're in the capillary bed, that is from microaneurysm closure. There's been focal closure from chronic long-standing hyperglycemia leading to glycation and advanced glycation end products that damage the pericyte and lead to microaneurysms and focal closure at the capillary level. When those blood vessels leak the blood, that's going to be intraretinal hemorrhage. And because the retinal photoreceptors and all the elements are aligned in a vertical manner, what you see is the hemorrhage appears to you as dots and blots. This dot and blot configuration of the hemorrhage is intraretinal hemorrhage. And the most common thing we see for that is diabetes. So non-proliferative diabetic retinopathy produces dot and blot hemorrhages that are intraretinal because of focal capillary closure, breakdown of the blood-brain barrier and the blood-retinal barrier at that location, endothelial damage from loss of pericytes from chronic long-standing advanced glycation end product damage, lipid peroxidation, and death of the pericyte leads to leakage. If you're on the venous side, the way the hemorrhages occur is there's an occlusion. So you get a thrombus, and that might be a central retinal vein occlusion or a branch retinal vein occlusion. That will increase the venous pressure, and that venous pressure can be central or can be transmitted right into the central retinal vein. And if you get the back pressure, the blood will come out. And those hemorrhages, if it's a central retinal vein, will be 4-quadrant hemorrhage because the blood can't get out of the eye. So it's not pressure on the artery side, it's pressure on the vein side, and the vein is very thin-walled, and so the blood just pours out. So not only blood pouring out, but exudate and fluid, and you get edema. And so we can have hemorrhages from a vein occlusion that's either going to be in the distribution of the branch retinal vein or the whole fundus. That's a central retinal vein occlusion. So when you look at hemorrhages, we need to know 3 things. Number 1, what level is the hemorrhage? Is it a flame hemorrhage, a dot hemorrhage, a blot hemorrhage? Is it under the retina, in front of the retina? And wherever it is, that's where the bleeding was. The most common things, hypertension and diabetes, but it can also be vein occlusion and hypercoagulable states and 10 million other different things. So from a neuro-op standpoint, what I'm looking for is, if I see hemorrhages, I'd like to know where they came from and why are they there. And in order to answer those questions, you must say what you see, not what you think it is. So the overarching point of this video is just write down what you saw. Then make a differential diagnosis of what you saw based on the level of the hemorrhages, how many hemorrhages, and what layer was affected. And you're going to start with common things are common, diabetes and hypertension, vein occlusions. These are the top things. And that's super important because we'd like to make sure it's not retinal disease before we blame it on neuro-op.